them for fuel as intended. For this reason, early diabetes specialists would often discuss the disorder as an intolerance for carbohydrates, or more simply, an intolerance for food itself. Until the discovery and purification of the hormone insulin in 1921, the first advice a doctor would likely give a newly diagnosed patient, occasionally the only advice that might confer any benefit, was what to eat and what not to eat to lessen the burden of the disease. A few of the 19th century physicians writing about the disease suggested that those with diabetes eat predominantly carbohydrate-rich foods, starchy vegetables and grains, sugar and potatoes, with the hope that their diabetic patients might compensate for their inability to metabolize these foods by consuming more of them. Most of the physicians of the era, however, took the opposite approach. Since those with diabetes could not metabolize carbohydrate-rich foods but could metabolize fat, they told their patients that fat should make up the bulk of the diet. Patients were always urged to take more fat, wrote Elliot Jocelyn, who by the 1920s was the most renowned and influential diabetes specialist in the United States, if not the world. At one time, my patients put fat in their soup, their coffee, and matched their eggs with portions of fat of equal size. The carbohydrate was kept extraordinarily low. For a century now, diabetes textbooks and chapters on diabetes therapy in medical texts have invariably included some variation on the statement that diet is the cornerstone or the foundation of diabetes treatment. As I write this, the most recent guidelines from the American Diabetes Association refer to dieting as medical nutrition therapy, MNT. The word diet is now seen as connoting only a temporary way to eat, something you go on and then off, not continue for a lifetime. MNT is seen as integral to diabetes therapy. What constitutes MNT, the dietary recommendations themselves, has been driven over the decades not by any meaningful research comparing different dietary approaches, but by advances in pharmacological therapy for diabetes and new methods to deliver insulin, lower blood sugar, and monitor blood sugar. Patients suffering from diabetes are no longer instructed to avoid specific foods or food groups. Rather, they are expected to follow the same healthful eating pattern that government agencies and health organizations recommend for all of us: vegetables, fruits, legumes, dairy, lean sources of protein, nuts, seeds, and whole grains, albeit with the expectation, if weight control is necessary, that they restrict their caloric intake. Controlling the symptoms and complications of the diabetes is left to insulin injections and a pharmacopoeia of drugs that work directly or indirectly to maintain blood sugar levels near enough normal that the specter of diabetic complications may be reduced. High blood pressure and the other complications that accompany the diabetic condition can also be controlled by medications. It is assumed that this approach is easiest on the patients, allowing them to balance the burden of having to inject themselves with insulin regularly, or wearing an insulin pump or taking the necessary hypoglycemic blood sugar-lowering drugs against a greater enjoyment of the pleasures of the table and eating, much as their healthy non-diabetic friends and family do. In 2009, the British diabetes specialist Edwin Gale, writing with his dietitian colleague Lynn Sawyer, described this situation aptly as paying lip service to lifestyle change as a means of controlling diabetes. Life under communism, Sawyer and Gale wrote in an editorial in the journal Diabetologia, was once summed up in the wry comment that we pretend to work and they pretend to pay us. Our patients might equally complain that we pretend to offer a diet and they pretend to follow it. Sawyer and Gale, knowingly or unknowingly, were repeating what the New York City diabetes specialist Edward Tolstoy had written in 1950 when he explained his rationale for what were then called liberal carbohydrate diets or free diets. New patients would come into his clinic at New York Hospital, Tolstoy explained, and they would leave with very carefully calculated diet plans and a program of minimal insulin doses that would keep their urine free of sugar, a sign that their disease was seemingly under control. We learned quite frequently that a patient would leave the clinic after having been complimented on his excellent cooperation and would go